good cross-sector to represent the different perspectives that we have in the state of Iowa on this topic. So, question 1, what is an assumption that people make about your role that you want to clarify today?
I'll go first. Mostly I'm thinking of an assessment that I did yesterday. I think, so our goal is to assess every patient that is coming to transplant. Ideally, we are assessing every person who's ever diagnosed with cancer. That doesn't happen all the time. So when they get a call from the social worker, I think they think there's something wrong, right? And that, well, I think that they feel like they're going to be evaluated. And that's really not it. And one of the first things that I say, I think it was one of the speakers from the previous session, every person is an individual with a different needs, with a different way of hearing information, of processing information, or understanding where they're at. Or there are different situations in their life. I do a class for new oncology nurses, and one of the things that I ask them to do at the start of the class is to just picture someone. Anyone, can be anyone. Because cancer affects everyone in different ways, depending upon where you are. So that's what I tell people when I'm first introducing myself, is that I'm here to get to know you and your situation. The benefit is that I have learned from every person that I've worked with before you. So you get to learn from their situations and my situations, but it doesn't matter if it doesn't apply to you. So I think that's it, is that it's very individualized, and it's really more of a conversation than it is like a plan, you know?
In a rural setting, it's the resource allocation that you need one dedicated individual all the time. That's just not the way it works when you're dealing in rural healthcare. It's finding the individual who's passionate about going above and beyond. Some people don't want to be that investigator. They don't want to be that connection person. They want to just focus on clinical. A navigator doesn't have to be clinical. A navigator can be somebody who brings that passion of connection. It could be a front desk staff who really finds value in getting people to other offices that need to have additional services or making those connections. I think that's one assumption, is it has to be a nurse or it has to be a social worker. It has to be the best fit for that individual setting, is what I feel from a rural perspective.
A lot of what I experience is a lot of what you were talking about as a social work role. It depends on how you approach the patients. You know, if you tell them you're a social worker, sometimes my therapist will say, the social worker wants to visit with you today, and people put up their arms and go, I don't need a social worker, I'm fine, you know. And I just explain to them, I talk to everybody. It's just, you know, I just want to be here for you, to support you, to help you, to let you know what resources are available. And I think that's one of the assumptions that people don't understand, is that I'm not there to criticize them or to counsel them, but to support them and to help them find resources and things as they go through their cancer journey.
I would just say sometimes I think people think navigators all you do is transportation. That certainly is a big part of it, but it's so much more. It is it's being there on the phone when they're first diagnosed, or they have a recurrence. It's walking them through that. It's providing anticipatory grief or anticipatory education for surgery or thereafter. It's talking about, it's being just that kind of person who can be a sounding board for the grief. And not just grief in terms of a physical loss, but why are the people in my life not here for me? Why am I now, my hair's grown back, I'm back at work, but I'm not fine, but I keep telling everybody I'm fine. But I don't have a place anymore to talk about that because nobody knows what to do with me now. So I think that's where our roles can be very unique to fit in where people need us most, and in ways that certainly are addressing those very logistical things that keep them from accessing their care or getting to care consistently or any of those things. It's lodging, it's patients who come from, you know, in Des Moines, we see patients as far south as Sheraton and Leon and Lamoni and up to Fort Dodge and over to Carroll, almost quite to Carroll and almost quite to Grinnell. And so those are patients who might be coming just for their surgery, or maybe they come for the radiation. So yes, we are helping them with lodging or finding those things, but it's also identifying what are the other resources that you need in your hometown. It's not that we have to solve everything, but I always like to say we're kind of a bridge to help you find not only the resources within our community, within the Cancer Center, but what's maybe also that you maybe don't realize. Maybe you're underutilizing your own benefits, or if you're a veteran, or if you're all these other things, you may not just realize. You may not realize your post-mastectomy bras and equipment that can be covered by your insurance. A lot of stuff is just people just aren't aware of what they have access to, and so we can be those people to just, again, help along that way. But we also, I think, have the real privilege at times because of the relationships we can build and the trust that we can build. It's also helping patients then to work through how do you ask questions, how do you have those hard conversations with your doctor? How do you ask, like the conversation we heard today, how do you have those hard conversations about getting a second opinion, or asking about, is this test appropriate for me or not? Or, you know, I'm not gonna see this goal. And so we help with legacy building. So maybe we sit down and we help write those letters that they wanna give to their kids that they know they're not gonna see. We get to be a part of those moments. So we get to see, I think the part that we all love is we get to be a part of not only the vulnerable and the raw, but also the joy, but everything else in between, and just empower and educate and support our patients through all of those things, and normalize it and validate it, and also let them just know that they're not alone, and that we can be of hope to them in whatever tangible way they need us to be that. Because I think that's the biggest thing, is when you're diagnosed like this, there's a real, I don't know that I have next. I don't know what that looks like. And then if they're able to get there, you celebrate, but then it's also helping them, oh, now what do I do with this next? And what does that look like? So that ability to then take them and walk with them along that in survivorship, I think those are the things that people just don't understand. All of the different ways we can be to patients and families. It's really whatever they need us to be, honestly. So.
Well, I'm going to swallow the lump in my throat. Everyone take a moment if you need to do the same thing, because that was beautiful, Jen. I just thank you, ladies, for everything that you do. We're going to hear that a lot today, but just moving on to the next question. So there's going to be a two-part to this question. The first part is, from your perspective, what is currently going really well in patient navigation? It could either be systematically in the state of Iowa or from your seat and your roles. You can tackle that whichever way you want. What's going really well for patient navigation?
I think this panel, conversation, people making it aware that there's possibility, there's opportunity. It's not a one-size-fits-all, that the conversation is being had, and that groups of individuals are coming together to improve what navigation looks not only in the state of Iowa, but this is going to also hopefully become a national conversation.
And the facilities are accepting of that. It's not just a clinical role anymore. It's not looking at the patient beyond just the clinical part of it, but also meeting their needs physically, emotionally, socially, economically. All of those different needs are being met now, which is huge and a great plus for our facilities in the state of Iowa.
I agree completely. I think also just the willingness of administrators to see that there is need for that because I think we're also talking about value, like where do you find value, because you do have to sell it to your administrators. And I worked over the last 2 years to really advocate for another position, and we got it. And I was using specifically challenging cases where we were able to pre-plan, but think of what we could do for everybody else if there were more. And so I think the willingness of administrators and all of us together as a community to have these discussions, everybody wins.
And I think it's not just a value-added service or extension of the team, the collaboration across silos, because we all have them in different ways, even with whether we're in a large community setting or within embedded in, clinic kind of setting or radiation. But I think too, we can all also further extend those services. A lot of it, we facilitate support groups. We help facilitate and work within our tumor boards, if you're familiar with those. Those are all quality things that can ensure the outcomes for our patients, that we're ensuring better consistency, that patients are, that we're discussing situations like this, that we're ensuring, yes, patients are getting markers tested, that that's a consistent thing, that they're getting opportunities to get neoadjuvant chemo, and that could be something that they, excuse me, come from a different setting where maybe the surgeon isn't aware of that. That's an outcome, so we can advocate on behalf of patients through those conversations that get had at those kinds of team meetings. But I also think it's the things that we can do by phone calls. That's a simple, cheap intervention, but a phone call can identify somebody's just not right, or they're not feeling good, or I didn't want to call the doctor, I didn't want to bother them. They're so busy. Well, tell me a little bit more about that. And then you start talking, and they're like so dehydrated, and that you just saved a hospitalization. So if people want to look at a bottom line, IV fluids are a lot cheaper than somebody ending up in the hospital with electrolyte imbalances and all the other things. That's where our roles can make a difference when you look at nurse-led phone call triage or some of those kinds of things. But it's more, it's about the collaboration, communication, but ultimately, that's what, it's about patient advocacy and being able to help tell that patient's story. Because sometimes, especially when you come together in a big meeting like a tumor board or something, the doctor, they may not know all those other social issues that that patient has, or as you guys all have seen it or heard it, well, they're this, they're anxious, they're high maintenance, you guys all know what I'm talking about. Well, let's maybe get to the root of why they're high maintenance or anxious. There's probably a reason there, and it's not about non-compliance. There's some real stuff there that if we really got our financial or our social worker involved, or a counselor, or some of the other things, they lost their husband before they even walked in the door. Let's meet people where they're at and give them a sense of grace and a space where real healing can happen when we just have a conversation and we get to know each other. I'm just going to get on a little pedestal to what we talked about today. It's about deep communities, right? And are we willing as nurses, as social workers, as community members, as physicians, as everybody who's in this room here, are we willing for any change to happen? Are we willing to really engage and be vulnerable, but be willing to engage and build deep communities within our communities? Whatever that means, because it's like the whole adage of, well, what's the best thing to do if somebody is sick? Bring them chicken soup. That is awesome, but do you know your neighbor enough to know, are they sick? Okay, now I know they're sick. Do you even like chicken soup? I don't know, maybe you like pho, maybe you like ice cream when you're sick. Or is it also, I know you're sick, I don't know if I have enough, that's not enough for me to move with my actions to go get you the chicken soup. So that it's all about what are we willing to do to really engage and want to be involved in our patients' lives, in our hospital settings, our communities, because that's how we're going to change screenings and any of the other stuff, is if we're really willing to engage with people and get to know people and put down our guard and want to build deep communities with one another and enrich. I'd rather go be a barista than take care of cancer, but this is where my heart is, but I hope we can get rid of cancer. I'd rather go make coffee, and the worst thing I do is not make it hot enough, or not give it enough foam or something, so it's relationships.
And I think the whole navigation piece too is for the patients, but it's also for the centers that you're all in as well. Because you're communicating with the doctors, and you're communicating with the nurses, and you're communicating with the social workers and the dietitians, and you're making sure that the patient's getting everything that they need, no matter what discipline it is.
All right, are we ready for the next question? Do we have any more to add? You guys are just knocking out of the park. You're doing a really good job. Okay, so we're going to go to the flip side of this coin and get a little nitty gritty. What is not working well in patient navigation? Again, could be specific, goal specific, or kind of statewide, kind of state of the whole.
I wish there was some monetary reimbursement associated with it, because it's a lot of time in that role. It'll be a long ways until that ever happens, but I think as administrators, there's always has to be a value in a dollar amount that you have to justify to the C-suite. I know what those people bring to and that physician brings to my patients, but they're not down there seeing it. They want to know, how's the bottom line going to happen. I wish we could take the bottom line conversation out of it and make it more about the value and what that leads to our patient care and our better outcomes. And for us, if we can have a good communication with the larger centers where patients may or may not be getting referred to, we get those patients back. So there is a value to that when it comes to a monetary side of it, is we can get patients back to our communities and be able to take care of them closer to where they live and work and stay engaged.
One of the things that I find difficult is sometimes finding the resources that the patients really need and deserve, especially with COVID. In rural Iowa, we've lost a lot of our transportation providers through COVID, and that's been a really big struggle financially and just because they're just not available. So that's one of the things that we really struggle with, and one of the things that if I would create a transportation to help these people get to fun, instead of having to try to find volunteers and make sure the volunteers are healthy and that they can get patients to and from. That's one of the things that I find that's a struggle. Another thing that I find as a struggle is when patients are no longer able to work, there's that 6-month disability where you have to be disabled for 6 months before you can qualify for like Social Security disability. And that's a real struggle for a lot of patients, because what do they do in that 6 months as far as the funding aspect goes? How do they pay their rent? How do they pay for their food? How do they, they can't work, or their work doesn't allow them to work because of their diagnosis and things like that. So that's another thing that's really difficult that I find with patients.
I would agree with that. I would also say COVID has really done a number on supports, like social supports. The social supports that were there before are not anymore. And also too, healthcare providers are tired. And so Dr. Richardson said when it gets messy, that's when you gotta lean in. And that's hard when you're tired, right? And like, I can't tell you how many times where somebody is really upset, and that's the time to take a deep breath and lean in. And you gotta dig a little deeper, right? Because the volume is more. The volume from your coworkers, the volume from your patients, all of that, it's more. But really, if we can be present in the moment, in that space, and give people space, then we're really there, right? And that's why we're here, is for them. And so like sorting through it piece by piece and trying to, I don't want to say recreate, but like invite those people back to the table. So like, and I don't know how we do that, because the caregiver support is really diminished. And I would tell you that that's probably the biggest trump card I can see in somebody's treatment plan. If you've got another person that can be there at those appointments with you, hearing the information, helping you process when you leave, bringing you the soup or whatever else it might be, like good caregiver support I think is huge, and I think that's what's missing right now.
I would say certainly, when I look back over just the past, my career of nursing, what I've seen really, especially in what I think COVID did too, and just what our knowledge base has had to grow to is, I could count on one hand how many homeless patients we would have in a year. I mean, it was few and far between. And I can tell you right now, we have just 5 right now that I know that we're all working with. And so when you look at what COVID did, but then also, a lot of those programs like Impact for housing and rental assistance, energy assistance, some of those programs now, they're out now. So patients had we had some safety nets to work within. A lot of those, they're no longer. And so it's challenging to us to keep up, okay, we know Impact has you got to get those in before a certain date, or we can help here. But it's also building coalitions and collaborating within the community, finding who is doing that work. Where can we utilize this? Because I know how to solve like this much, but I don't know where to get them. Because it's not just about, I want to help them get from A to B in their cancer treatment, but I want to know big picture, holistic, they've got somewhere to go after, and that they have that safety net. And that we've enrolled them in Medicaid, or we got them on the marketplace, or gosh, with breast cancer, for example, let's try the Pink Fund or Komen, see if they qualify for some of those financials. Fortunately, at the Cancer Center, we are really blessed to have a lot of philanthropic dollars, so we can utilize our Compassion Fund or do that. But again, that's not going to solve everything, and that's not everybody has that. And it's unfortunate to see where just in our society right now, the financial burdens and housing, just like you said, gas, just having money to fix a car reliably, not having a person, you know, you'd be amazed how many people don't have a person who can reliably or will want to even stick around long enough to take them to their treatments. And so how we become their person then to help them find that safety and a refuge at home, not just within our doors, but that they can go home to. That's probably one of the biggest challenges just over the past couple of years that's really been highlighted. But thank you to Kelly, and like with the ACS and the Cancer Consortium that does have grant programs like for gas cards and some of those things. Or if you're ever a patient or a family member and you're like, what would be a nice thing to give to somebody? Give them a gas card, give them a meal card. You don't realize how important some of those things, what that difference that can make to somebody. Or if you donate them back to a cancer center or to a rural cancer center, especially that has less resources than in even Des Moines, that'd be huge, just having something tangible to give to somebody to be able to feel like you help them in some small way. But that can be huge to a patient.
And thank you guys for those answers. So there's about 10 minutes left with our panel, and I know I personally feel like this is just flown, and I do want to make sure if you have a question, I would like to open it up for questions just from the general room. So if there's anyone who has a question for the panel, I want to make sure we leave space for that.
Yeah, I have a question about like telehealth. How have you seen positive, negative of telehealth? I know in COVID it was like a big surge, but is that continuing? And how do your patients, especially in the rural communities, number one, are there towers there for them to even be on internet? And two, do they even have the tools to be able to interact with healthcare professionals? And I'd just like your opinions on that.
Honestly, for us, during COVID, we never shut down. We kept functioning the way we were functioning before COVID. Patients had to come in alone, unfortunately, without a caregiver or anybody along. They did come in our waiting room, they sat in their cars until we called them, and then they came in for their appointment. So we did some minor adjustments through COVID, but thankfully they were still able to come in and see their provider face-to-face, which was a huge plus and a huge benefit. I think because we were rural and had limited numbers, limited space, we were able to continue to do that. If they had to see specialists, then we would have them either, if they didn't have internet access at home or the ability to be able to do that, then we would bring them in. And I know I have helped facilitate several from my office of different people who had to contact their doctors, whether it be in Des Moines or Mayo or wherever.
We were in the same boat. We still continue to see patients. Our nurse navigator came on board at that exact same time, and she would take notes. She would call in family members and have them, she would do follow-up calls. It really happened at the most perfect time for her position to come about because that's exactly what she was doing. I come from a community where if grandma's got cancer, the 5 aunts come with. So we built rooms in order to accommodate, never knowing that COVID was going to make those rooms more viable. In our telehealth visits, we limited mostly to our nursing home patients. We would, if it was a follow-up call or a follow-up visit with a nursing home, we would get the family on the phone and we get the nursing home on the phone and we get the patient on the phone, trying to kind of limit the visits that weren't necessary, but very similar. We still saw patients, they still came in, and telehealth really didn't take off because our patients want to see their providers.
So for the stem cell transplant piece, we're a specialized center, but I think we got more comfortable sometimes spacing out our visits, so we still have to see people in person, but obviously too, we want to get people back to their home communities, right? They want to be in their home communities, they don't want to be driving however far to get to Iowa City, and so I think it made us a little bit more comfortable with what we could space out, so it kind of forced us to try some new things.
thinking of some of the cancer centers, the larger centers, I think we already had a built-in navigation network because a lot of our providers are shared from the same group. If somebody would be seen in Des Moines and then they've got a provider, Mission Cancer, we work with, they would be able to consult with the doctor that comes to Carroll. I mean, we already had built-in navigation just because our teams are so small and close-knit already, and now when you add a personal role to that, it just made it even better. The Navigator became the glue to all of those clinical professionals that focused on their particular area. Now you've got somebody who can weave in between each department and be with that patient and actually support the providers and the clinical staff too.
All right, you have some other questions? Sorry, I saw you first.
No, so you mentioned two kind of key things, like having a change agent, superhero kind of running and working in this program, and also monetary reimbursement. Aside from those two things, what are some tips or guidance for scaling up a pilot patient navigation from like a grant to like a full-time program, especially for Spencer and Carroll?
I think tracking. Our Navigator tracks how many in and out phone calls she makes, and those are phone calls that were going to the clinical teams. So just last month, I think she had 175 outgoing calls and just as many incoming calls. Those calls all take time. That's not including emails, filling out paperwork, connecting with social work, going to see the inpatients. Tracking where you see those resources being used will validate the positions. If you don't have the numbers, you can't prove the value. So she tracks all of that, and then I present that to the board, and I present that to administration of where's the time going. We had one patient who was particularly challenging. She spent probably 5 to 10 hours a week on that one patient. And that was just to get him to treatment each week because we had transportation problems, communication issues. But if she didn't do that, that patient would have never came, and it probably would have been a bad outcome at the end.
Yep.
And that patient shows back up and asks for her once a month. Because they built that bond. But yeah, it's tracking where that time and the resources is, because time is money.
And you can add in, if they're looking for dollar amounts, you can add in those dollar amounts. So like, if I'm working with a patient who needs to be on an oral chemotherapy medication, and that oral chemotherapy medication is gonna cost them $3,000 out of their pocket every month, and they can't afford it. So that changes the whole perspective of how they're gonna be treated, right? So if I can find a copay assistance program to help them, or if I can get the medication for free through the drug company, that's a $3,000 savings that the hospital's getting right there, just for that 1 month of medication. And so you take that times 12 months, right there's your dollars, that you can prove that it's a needed service for those patients. And that's almost every Medicare patient has those kind of copays with any kind of oral chemotherapy medication. And so that's a huge piece, and that those dollars add up.
Yeah, financial navigation that's a whole other animal.
Building on that, I would also add avoidable days. So if you have a situation where you can avoid an admission with like electrolytes or outpatient fluids or something like that, as opposed to doing admissions, and you can track those. So you can track like how your calls come in and what intervention is used. So avoidable days is a big one with administrators.
One of our inside kind of laughing jokes is 20% of our patients take 80% of our time. It's not the 80% of the patients that are easy, it's the 20% that really need that person. So every month we get a new 20% that kind of comes through the door and need those resources more than the next. But it's also not letting those patients who you didn't think needed anything fall through the cracks. Because that initial conversation, everything's fine, they've got resources, but nobody knows 6 weeks later unless you ask the question, how are you doing? Has anything changed? It's having people to do those follow-up conversations, which we didn't have. We're just building that piece to have those follow-ups with social work and the navigation. So yeah, the 20%.
We might have time for one more question if someone has a burning question that we can answer lightning round. Deal? Okay. So if anyone has a burning question, Georgia?
I have a question. So in working with patients, there are sometimes, actually you may have a difficult
things happen in different places that were beyond our control, but to a patient, we're all seen as one entity. Whether it happened at their surgeon's office or in the hospital or down the street, well, that's John's daughter. Well, no, it really isn't, but I'm gonna do everything I can to make your experience good. But I think it's giving people permission that, you know what, sometimes it's just not a good fit. And you have to, I think with patients that this is a person that you're gonna have a relationship with a long time. And if you're not able to have a candid, honest conversation, not just about the treatment, but what are your goals? What matters to you? Because we can do all kinds of things. It's easy to.
Are you speaking as a patient or as a physician?
I'm speaking as a nurse to the patient. We can do all kinds of things to you. We can give you chemo. We can cut. We can turn a laser on. But if that's not ultimately in congruence with what your goals are and how you want to live your life or what quality of life means to you, you have every right to say no. You have every right to go get a second opinion. And even if that second or third opinion tells you the same thing, but if you just need to hear that so that you feel more comfortable and confident in however you choose to go forward, you have every right. But if you don't feel you're being heard by your team, then you have every right to seek out another. There's ways and channels that we then work through to help the patient, because we don't want to get caught in between that and never look like we're pitying one doctor. I would never say one thing like that. But it really is about the patient and their relationship and the trust and that ability to communicate at all levels. So helping them get to wherever they need to feel comfortable and confident is what I try to do with patients.
Final comment on this
And
question?
with our center, we just have one physician in our center, and so sometimes it is getting the information from the patient and going back to the physician and having that conversation with the physician. And I'm so grateful we have one that's receptive to that and will help facilitate that, make that better for the patient. Like, she didn't understand something you said, can you clarify that for her? Or, it's kind of that role that you have to play sometimes. And sometimes, depending on the mood of the patient or the doctor, it doesn't go well. But you can kind of help navigate that to try and help the patient feel like they can approach the doctor with their concerns or their questions.
All right, sorry, I gotta cut you guys short. I just wanna make sure we switch out. So can we please get a round of applause for our panelists?